Unfortunately, none of the patients that I had during our physical clinical hours I had for longer than a 24-hour period, whether they were discharged, left on their own accord, or were transferred to a different unit. Um, this patient was transferred. Patient is 92 years old. DNR at 79 kilograms. I couldn't find a height. I don't know why. She didn't seem to know when I asked her how tall she was, or even what she used to be. So, but it's fine. She came to the ER with shortness of breath from her assisted living. A chest x-ray was performed, and it was found that she had a bilateral lower lobe pneumonia with atelectasis and a small left pleural effusion. She does have cardiomegaly, but it does not have overt CHF. So after her x-ray, further labs revealed that she had an elevated troponin, and so she was then admitted. For history, she has no respiratory history. She never smoked, never, not once. For medical history, she had bilateral total shoulder replacements, rectal surgery. It was not clear as to what that was. Hysterectomy, a gallbladder removal, cataract extraction. That was about it. Nothing too wild and crazy. Medications, she came with the usual, Tylenol for pain. But she did come with Toprol XL, 100 milligrams once a day for high blood pressure. PRN potassium chloride injections at 40 MEQs every time potassium is drawn. She did have a PRN dextrose, 50%, 12.5 grams, but it's unclear as to why, because she does not have a medical history of diabetes. She's also on Rocephin, IV 1 gram, 100 mils every hour, every 24 hours for pneumonia, and Zithromax for IV every 24 hours for pneumonia. After further research, those two antibiotics do have a side effect of increased blood sugars, so fasting blood sugars, so I'm leaning towards that, maybe why she has the PRN dextrose. For respiratory treatments, we ordered Duoneb 3 mLs every 4 hours while awake, SVN for wheezes. She also is on an EasyPap. 2 days post-admit is when I encountered her for the first time. She was labored breathing with accessory muscle uses, and she had wheezes throughout the right lung and was diminished throughout the left. However, her vital signs were actually really, really good. Heart rate was 65. Her respiratory rate was a little elevated at 28, but her SpO2 was 96 on room air. she honestly, her skin was pink and warm, and she must have taken fairly good care of herself. She looked, I would not have guessed 92. I was thinking like 70s, late 70s. She looked very good overall. She was alert and oriented. Her chest expansion was even, considering, and she was cracking jokes. Her pastor had come in and visited with her, and she was able to sit and talk with him without any, increased labored breathing. Like, she did pretty good. It was very interesting. Her blood work from the day that I encountered her is as follows. She had a white blood cell count of 9.2, a red blood cell count of 4.03. Chloride was 111. Her BUN was 20. Her creatinine was 1.04. Her hematocrit was 34.1, but her sodium was 143. Potassium was 4.1. Her albumin was 2.9, and she had an ever so slightly increased glucose of 139, but like I said, her antibiotic that she's on does have a history of it can increase your blood sugar. So, and she had a elevated troponin of 0.07. So the decreased albumin is likely an inflammatory response to the pneumonia. And her elevated troponin indicates that she does have some sort of a cardiac issue, as does the decreased hemoglobin. So while the wheezes and the shortness of breath are consistent with the pneumonia, the shortness of breath is also related to cardiac issues. So it's hard to say what exactly is causing the shortness of breath. She had a chest x-ray performed the day that I interacted with her, and when I reviewed them, her costophrenic angles were not visible, with air bronchograms on the left, infiltrates in the right lung, and she had a completely flattened diaphragm. Her heart was enlarged, and there was I'd say a moderately sized pleural effusion in the left lung. The MD interpretation was worsening pneumonia and pneumonic effusion at the left lung base, improved aeration at the right lung base, although there is a diffuse interstitial pneumatitis. On the following day, there was a chest x-ray was also performed, and I interpreted it with costophrenic angles still not visible with either lung. The pleural effusion had increased in size greatly, and in the left lung. But there was no MD interpretation for the entirety of that day. So I'm not sure the MD's opinion on the matter. But if I had to guess, it would indicate the same. During a treatment that I was administering, a physician did come in and visit her and mentioned that a pulmonologist would be in touch, and they were thinking that she may need a, as he put it, a chest tube. So I'm assuming that was the game plan for the next day. But later that evening and into the next morning, the patient started to experience an increased shortness of breath and left arm pain. An EKG was performed and it showed AFib with RVR, and her heart rate was 161. Pain meds were administered, and she tried repositioning. Nursing did everything they could, and they ended up having to, after consulting with her physician, they transferred her to CCU. And that was the last time I saw, I never saw this patient again after that. My guess is that the patient's heart was failing before she got sick. It's just the pneumonia and the subsequent pleural effusion started to cause more stress in her heart, and there she was. The recommendation I had for her would be to continue with the antibiotics and the EasyPap, Duoneb, and perhaps introduce a steroid. Continue with treatments and plans that cardiology and her primary physician would be starting. The severity of my patient's illness is pretty up there. Even though she's an overall healthy individual, given her advanced age, it could take a while for her to get well again. She could be feeling the effects of the pneumonia for a number of weeks, and if she did end up getting a drain for her pleural effusion, I imagine that's going to take even longer to recover from, if she recovered from. My concern is that the pleural effusion had gotten larger and worse so rapidly that the longer it was left untreated, that she would become septic, and this would then cause damage to the other organ systems. Outcome-wise, for the short term, as I said, I imagine it's going to take a little while for her to get better. If they manage to get her cardio issues stabilized, then I imagine she would continue at the hospital with treatment for the effusion, and then go back to her assisted living until she showed improvement with that. Long term, she could potentially go back home to her assisted living. She could. Like I said, she was a relatively healthy individual prior to this, so there's a chance she could be fine. If she would go home with an incentive and O2 if she needed it. As I saw her, she was not hypoxic, so I don't believe that would have been something she needed, but potentially. DuoNeb PRN and deep breathing exercises to help keep those lungs open and ward off the atelectasis and dyspnea. The problem is that it is a community-acquired pneumonia, and given the time of year, my concern would be that if she did go home, that she would just contract it again, depending on the size of her community. Because apparently she was still quite active prior to this. I believe that the AFib and the RVR, the rapid ventricular response, was due to the pleural effusion. So I believe those would hopefully treat themselves. Like once the effusion is taken care of, then the effects from the AFib would go away. So I'm not too concerned about that, but she was, again, I never saw her after that. The disease process I covered was for the pleural effusion, because the pneumonia wasn't so much the problem. The pneumonia is what caused the majority of the problems. So I did pleural effusion. Patients with a pleural effusion are expected to present with chest pain and dyspnea and a cough. They could have tachypnea, a decrease in compliance, and an increased vent rate, hypoxemia, cyanosis, diminished breath sounds, dull percussion note, even a pleural friction rub. A chest x-ray would include blunting of the costophrenic angles, a visible fluid line, depressed diaphragm, atelectasis, and meniscus sign. Would also include an increased respiratory rate, heart rate, and blood pressure. Typically with pleural effusion, you would expect the patient to have pneumonia or CHF, a PE, or tuberculosis. This patient obviously presented with pneumonia. She had dyspnea and an increased heart rate, increased respiratory rate slightly. She was overall not feeling well, but she looked good. She did have that increased work of breathing with the accessory muscle use. She had wheezing, which I assume is from the pneumonia. Her chest x-ray had the blunting at the costophrenic angles, she had a fluid line, and she had atelectasis. And then, of course, the pleural effusion. And she had the elevated troponin. Again, I think the elevated troponin is a side effect, if you will, from the from the stress on her heart from the pleural effusion she got from the pneumonia. All of my research was done from her, besides her chart, was from the yellow pages that we did in pharmacology. The AFib and the RVR, I actually had to research in our cardio principles textbook, and I had to do some research in our pharmacology book for the medications she was on.